1st, 2020. And I was just announcing the items to be added as not reasonably anticipated by the chair 48 hours in advance of the meeting, and then we can vote to amend. But that item that we have there now, discussion, and I'll post in just a moment. I can't do both things at once.
Well, who is
Let's see.
Kate Clews?
The discussion of required deed recordings prior to septic installation, that's been pretty much resolved. So do we need to? Or I'll mention, I guess we could go over what people are asking us. Ellen? So,
Yeah.
okay. All right. So that is one, the deed recordings. And anything else come up today? I think COVID-19 will catch just about everything else. So, at least from my perspective, but all right. If there's nothing else, do we have a motion to amend the agenda with that item?
So moved.
Second.
All in favor? Oh, we have to do roll call vote. Daryl, aye.
Dave, aye.
Lisa, aye.
Matt, aye.
Rebecca?
Unmute yourself.
She's muted.
Thank you. Rebecca, aye. No wonder you didn't hear me.
All right, and I'll bring up the agenda in a moment. Let's see. Agent, have you come up with anything aside from our 7:30?
Mark's muted too.
I just got off the mute, sorry. I have not, outside of everything that's going to be just, it's pretty much every day we do the best we can out there in the outside world. I'm not going into homes, but I'm sure that'll be discussed with the COVID-19 information.
Yeah, okay. And we have food inspection report for review. Ellen, do you want to highlight anything on that?
No, just I emailed it to you so that you would see, his inspection, and he has correction dates, but I don't know if he's been doing the inspections since it was, just essential services. So that might be delayed his reinspection.
Yeah, okay. All right, and just to let folks know too, on the, besides food inspections, camp inspections, I've instructed him to review whatever materials might be coming in and applications, but let people know that we don't know if we will end up issuing permits for camps or not, so.
Wasn't there something, I thought that Baker had issued something about licensing of camps. I think there's been extensions and modifications of dates. Is that correct?
Yeah, he tried. I was on a DPH conference call yesterday, and one of the conference calls, and they talked about that. I don't have my notes from that right here with me now, but they did talk in the camp regulations. If it's an annual camp that the Board of Health has seen before, the board does not have to perform an inspection this year, but I don't know what this board would want for the one main camp that does happen in town every year. I don't know. Do you want him to still do the inspection, or?
I would like him to do what he can safely in preparation, like make sure that they've got their paperwork and their Corey checks and all the rest, because
they're supposed to have their paperwork in 90 days in advance.
Right.
I don't think they ever have.
Yeah.
No, they haven't.
So if you could relate to him that he should, if they're planning, hoping to have a camp, which again, can't be guaranteed, they need to do all that as soon as possible, to the extent possible.
Okay.
I would think a query check should be doable remotely, but can't guarantee what kind of accessibility the folks who perform those checks have to the systems they need. Okay.
Thanks.
I don't know if everyone, I'm gonna jump just in general. Has everyone seen the town website that has COVID-19 information?
I have.
Okay. If you get a chance, it's not as up to date as it could be. Everything takes a very long time to do. And we're working on getting a lot of stuff set up and a lot of coordinating. So the town team has been trying to submit updates, which then have been run through Zach Ward, the interim fire chief, and he's been making the updates. So at some point, he will probably be getting even busier. So we'll have to figure out what we do at that point. But I think they're also transitioning to a different style because we're getting enough things that we want to post that it's not as easy to follow in just a long list format. So it'll look a little bit more like a web page with sidebars and links and that sort of thing. And that might make it easier for others to update it as well. So rather than going through an administrative level authority to make the changes as it is currently. So, okay, let's see. Well, we have no minutes that we have to review.
No, sorry.
No agent's business, that's good. No, Ellen. I don't think you could squeeze another second out of the week right now.
There's not enough minutes in the day anymore.
No. And just so you know, Ellen and I speak every day on weekends, many times a day, just going through stuff and trying to verify information and get information out and coordinate among the different groups. So until our 7:30, well, let's discuss that one about required deed recordings.
Okay.
So do you want to describe just the email that came in and then?
Yeah, I received an email today or last night from Paul Saulnier about apparently they want to start a septic installation, but they haven't been able to do the deed recording because he said the owner is an elderly man who can't get to a notary because the document needs to be notarized. And, you know, has the board come up with a solution for this? I mean, this was the first I heard of it. So I was on a Zoom call this afternoon with all of the town hall employees. And so I asked, you know, does anybody know how someone could get a document notarized? And come to find out, Sue Kelleher, the COA director, is a notary. So I asked her, you know, would she go to someone's house? And she said, absolutely. I said, it's a senior in town. So after the meeting, I called the homeowner. I spoke to him. He said, yeah, as long as, you know, it's somebody that, you know, is okay to come, he would let her come to the house. And I did offer that if he wasn't comfortable her coming in the house, she could witness it through the door, you know, through the window. But he said, no, that would be fine. So after the staff meeting, I talked to Sue. I talked to him, then he gave me permission to give his phone number to Sue. Sue called him and she's going to visit his house tomorrow morning at 11. So he is all set. So this is a moot point now. He was very happy. He called me actually about a half an hour ago to let me know that he had talked to Sue and he's fine, and he knows that the recordings can be done electronically. And so,
Thank you for doing that.
yeah, it worked out. He was very pleased. So,
Sue's terrific. One thing I was going to say, Ellen, interrupting, is Jeff. I thought Carol Marple was a notary also.
yeah, she is, but
I
she
know
was on that call too.
She retired as of yesterday, I think, or
Yeah,
whatever.
yeah.
But she,
Yeah, and there are a couple others in town hall,
Mhm.
but they're in town hall, and
Yeah.
Carol didn't offer.
Yeah.
And I just felt, since he is a senior in town and
No.
Sue is the COA director, it worked out perfectly. It couldn't have worked out any better.
So
Right.
did they?
He had identified himself as self-isolating.
Yeah.
So he did not want to have to go out. So this
Yeah.
was a nice opportunity to
Definitely.
do it at home. And
Do they know that the deed buildings are all closed to the public, and so they're gonna have to do it by e-recording and mail recording? So
Yeah. Yes.
just making sure.
Yep.
yeah, so, and that was good because we spent some time trying to figure out some other ways to go about this. And in the end, realized that in our files, there are numbers of plans that people have never finished doing the last little bits for them. And there really is not any easy enforcement mechanism for us to make sure that something gets done. So if we didn't, and that's how the system of requiring the deed recordings before releasing a plan took place, is by the history of never being able to close out some of these things, have the deed recordings, whatever. So no matter, even if we put some other things in place now, there's no guarantee that it would work, since past efforts to do that have not worked. So it's good that this worked out. So we were thinking about just trying to reduce the stress for people, or what could we do in these unusual times, but it's the old slippery slope argument too. And actually Jean was great in pointing out that since she does a lot of the pulling of files for people, that she's often pulling files and seeing that there are things that have never had particular issues, such as deed recordings, resolved. So that made this discussion way easier because there was a solution found. All right, let's see, we have 6 minutes. Let's see, we could do it, and I see that perhaps Kristin Clews is on for the 7:30, so we will get to that shortly. But we could do some COVID updating. I don't know if you want me to just describe some of the things that have been going on, or if folks want to ask questions, and that might be the way to do it if you have
And just
on your mind.
I'd love to hear what
just remember that we're not giving out the numbers of cases in town.
Right, and
Publicly.
actually that's, yes, thank you, Ellen. Excellent to remind people of that, since the DPH guidance is that you do not give out town information. And frankly, my perspective is that town numbers are meaningless. It doesn't matter if we said 0, 15, 50, 100, or 1,000, it doesn't matter, because COVID's all around us right now. We have the state posts data every single day on the numbers of confirmed cases in Massachusetts by county. And Middlesex County has by far the highest number of confirmed positive cases. And
Actually, Suffolk just.
Suffolk and Norfolk are all right up there. So
Yeah, no,
there
Suffolk
is,
took over. Yeah, actually.
yeah, there's no way that Sherborn has somehow in a magical bubble that doesn't have cases. And
Well,
that,
that's also, I mean, it's such a small number of people even are getting tested, you know.
yes, and that's the other thing. We received some information today, or maybe it was yesterday, Ellen, about the criteria for when tests are done, because
Mhm.
the ability to administer the tests is limited. So you really have to be either a first responder, a medical professional, or have known contact with someone who's positive and have symptoms yourself before you're going to get a test. So the tests are just measuring a small portion of the population. Most of it's done now by people. If they're not feeling well, they call into their doctors. The doctors assess, has it reached the point where they need testing or they need some additional care? But for the most part, they're advising people, if you have fever, cough, nausea, certainly shortness of breath is the one that triggers going in for medical care, but any of those symptoms, and they just say, you assume you have COVID-19 and therefore stay at home unless you feel worse, and then contact them again. So that's how that is being handled. Some towns have been releasing the numbers, but
Yeah,
the
Dover.
doesn't really want that.
Yeah.
But some towns are pressured by
and I think
different groups.
And I think this is also clearer guidance than DPH has given in the past, where I think before they sort of had, you should be cautious, privacy is important. So it's a lot easier if they say you shouldn't do this, because I think that sounds like clearer guidance than they'd given in the previous calls.
Well, I'll say that they were
Yeah.
wishy-washy, though. They gave
Yeah.
guidance that they
Not
don't want
really.
anyone doing it. And then they said, unless you have reason to believe that there's something special about your town that you need to do it.
Yeah, and Dover apparently thought they were special, so.
Well, I think it was just like lots of different pressures. I think people are hungry for the information, but I think Daryl's point of having it be high or low doesn't tell you very much about your risk. And I would definitely say,
Yeah.
on the inpatient side, like on the hospital side, we're seeing that uptick. I think the current projections are sort of 1 to 2 weeks to peak, and testing has definitely gotten more available. But if it's not going to change management, like I would avoid getting tested, partly because as we see more cases, the places you're going to get tested, like if 5 out of 10 of the people who are getting tested with you have COVID and you're one of the other 5 before you get there, you may not be after you get there. And so unless you're hospital sick, it doesn't make sense to do it.
Yeah.
I was going to add one data point too, Matt, that we just announced today, because Quest has done a lot of the tests in Massachusetts, somewhere in the neighborhood of 24,000. Roughly half the tests done in Massachusetts were done by Quest. They right now have nationwide 166,000 backlog tests. They are now saying that Quest tests have a 10-day gap between the test date and the result date.
Holy.
And
Wow.
there's been a big uptick in sort of where testing is being done. So I think they're doing some at like BI is doing internal testing. I think MGH and Brigham are doing internal testing. I think the Broad Institute has started doing some testing, and then there's there's the various commercial labs and the state labs. And so I think for our hospitalized patients, the turnaround time's quicker, which is good, because if people don't have COVID, we've got dedicated units, and you would prefer to have people who ultimately don't have the infection to be on that unit for as short a time as humanly possible. But right now, our internal protocol is the test. I think the test is okay. It's not great. And so for our hospital, we're doing 2 negative tests to get out of the unit is our current approach. But I also would say, I think this point was kind of raised in a separate conversation. Like, if people have a negative test, they should still, if symptomatic, exercise a great deal of caution, because a test is certainly not totally definitive. I think it's a reasonable guidance and a reasonable tool, but a negative test doesn't mean that you should say, okay, I'm going to go visit my 98-year-old grandmother.
Yep. And isn't there a 30% false positive
I-
negative rate.
So I think there's a false negative rate that is somewhere in that neighborhood. I think some of it depends on which assay it is, and it's
Mhm.
also like how good a swab does somebody get.
Yeah.
This is like a deep nasal swab, so it's like right back in there.
Yeah.
And so I think that's the other question of like, how good is the sample that's being tested with the assay? So is this like an assay issue or a test issue or both? And so I think a lot of that they try to reduce in the higher risk areas by doing the second test to kind of try to reduce that more. And I think we'll see this continue to improve over time. And I think the other thing that's getting worked on that has not gone live yet in any significant way is serology testing. So what they're testing for right now is basically the genetic material from the virus itself. I think what becomes more interesting, Iceland's doing a big set of samples with this. And there's also, I think in Telluride, there's like a biotech company that has
They
decided to
did,
test.
yep.
And so
Mhm.
what they're looking for is to say, what's the antibody positivity? Because if we have minimally or asymptomatic people, the testing protocols and the limitations of testing will kind of overestimate the morbidity or mortality of it. And by doing the antibody testing in a population, you can identify, like the serology testing, you can identify those who've had infection but didn't get sick and didn't get confirmatory testing. So I think it'll be really interesting to see as that data comes back, sort of what that asymptomatic or minimally symptomatic subset is.
I agree. It's really
Can I make a subtle point regarding?
Okay, and can you do it quick because we can go to our 7:30 since it's 7:32 now.
Yeah,
Come back?
I can come back later.
Okay,
Okay.
great. So since we have folks waiting, so we have Mark, the 18 Prospect Street additional well discussion.
Yes.
Mhm.
Can you hear me okay?
Yep.
Yeah. Actually, Daryl, can you pull that up? Because can you pull up the information that Ellen sent around?
So your camera is not on.
Let me start.
No, it doesn't need to be on. I just need to share my screen, but I need to open up the document. So, Mark, why don't you start and I will.
So 18 Prospect Street was submitted as an additional well, but last Friday I spoke to the well company and they indicated that the well on the property that they're showing where they're putting this well, the old well's to be abandoned or has been abandoned. And I see the homeowners on with us. So that is the question at hand is indeed this an additional well or is it going to be the only well for the property?
It's going to be the only well for the property. They're just going
Okay.
to tap into the old one and reopen it, basically.
Yeah, that's originally that's what you came in for, is to reopen the old well, but I think you decide, is that still the decision or are you planning to drill this new located well they're showing?
Well, the old well was decommissioned, and
Okay.
from misinformation through somebody that it was told to them, to the new business that I
You
hired,
want to plug it in?
was to re-drill.
Okay, so the old well was abandoned and then the existing well is going to be deepened. Is that correct, Kristen?
It's just going to be reopened. Not
Okay.
I don't know what that particularly means, but
Well, it sounds like your present water is coming from this well, but you want to deepen it.
we're getting no water from this well. It was decommissioned, so we're just trying to reopen it.
I see. How are you getting water right now, if you don't mind me asking?
We are hooking up from our property on 16 Prospect Street, and
So-
it's been a pain.
So you're using someone else as well at the time then?
No, we own 18 and 16.
Oh, okay.
Mhm.
So
Yeah,
theoretically, this is an additional well, but you have two properties and you want a well
Yes.
on each property. This well that you're requesting to deepen, is it? Yeah, I think you're right. It did go through us before.
hmm
What will be the purpose for this well, if I may ask?
we're gonna use it for exterior usage, mostly irrigation, washing off like lawnmowers, stuff like that.
Okay.
It'd be nice to have that.
Okay, that's the question at hand. So
Okay.
the board likes to review it. even though it's two separate properties, they still have to review the
Okay.
process of an additional well, because
Okay.
obviously you have one serving your house, but you own two lots, obviously, and
Yeah.
you own 16 and 18 Prospect Street.
Yes, we do. And
So-
we couldn't combine the address, so we had to keep it 18 and 16.
Okay. Okay,
But
so I'll let the board make
There's
some
only
comments.
one residence though, so there's one residence.
Yeah.
But
Me, my husband, and our 3 kids. Yeah. hmm
right, so this would be an additional well, Mark.
Would it? Oh,
Yeah.
okay.
Yeah, because it's really it's basically one well per residence is what
Okay.
we had specified in the regulations, and that it would be on a case-by-case basis, because we actually were trying to dissuade people from putting in irrigation wells because it's a shared resource in the town, and there's a number of people who have had issues with their wells running dry.
Okay.
So we have to put potable use as a priority versus irrigation use.
Okay.
So
I mean,
yeah.
I didn't mean to cut you off. I mean, because we're so close to the wetlands, I don't feel as though that is going to happen. And since it is a different entity and I am on 18 and there is 16, can't we just go forth with that? I mean, it's not identified as one property.
But as she said, it's one residence. And if you're finding the use of the other well, you said it was a difficulty or a pain or whatever, however you referred to it, to be using the other well.
Yeah.
I'm wondering why you wouldn't want to switch maybe to the other well entirely.
Okay.
And also you're not likely to be drawing from the wetlands. You don't want to be drawing water from the wetlands. You're probably taking it from deeper than that.
Okay.
And that is a different dynamic when we're looking at bedrock. It's not easy to predict. And in terms of water use, we find that if people have reasonably producing wells, people are meeting all their needs from the one well.
Yeah.
So two have other risks besides just giving this false sense of you're tapping into more water. It's all the same pool of water essentially underground. And if you want to do irrigation of lawns, the time that people would want to be irrigating is during a drought, which is especially when we don't want irrigation going on, because then it's jeopardizing the supply for potable water. So, and then having two wells, one we feel can be forgotten and not maintained well, and it could be a conduit for contaminants or other things into the groundwater. So we do have a lot of reasons for not wanting two wells.
Okay.
Whether you want to consider whether you want to abandon the one you're using and use the other one and improve that and apply that would be a question.
So you're basically saying, okay, then run everything off the 16 Prospect Street well.
I mean, if there's a reason that you feel that if it was deepened and improved, that you would prefer to use that rather than what you're doing now, because it just sounded like there's something that's not completely satisfying with your current well. Is that
upstairs?
Yes, we aren't currently satisfied with it. That's why we're trying to propose opening it again. And unfortunately, when the property was purchased, it was decommissioned, and I wouldn't have that done.
Okay, hold on a second. There's some noise. So I can't tell.
Who's JM? Okay.
They're quiet.
Yeah, don't know. Okay, all right. Let's try again. Sorry. So, all right. So you're saying that something is not working so well, but I kind of missed what that was exactly.
I feel as though, I came at this, me and my husband came at this back in 2018, and it's been on a big hold since then. It was already signed off to be re-drilled. I mean, I already have been approved. I gave the permit, $450. I just don't understand why we're getting into such an issue with it now.
I think.
Sorry,
this-
you cut out there, at least for me. I'm not sure if that was for others.
Okay,
Your engineer
Want
tell
this
you about the town regulations?
into that same problem.
Well,
oh God.
so my curiosity is, can you be specific about what was done in 2018? Because I think the regulation that we passed would basically treat 2 properties with a single residence as a single property and not allow it. I think one of the key questions is, what
Okay.
was the state prior to the regulations passage?
Yeah. And, yeah.
Okay.
And maybe Mark, can you address that?
Yeah, this is an interesting case. Kristin is right that I think 4 years ago they came in and actually was surprised at that time they wanted another well just for the lot, but they decided on it. But then, and Kristin, correct me if I'm wrong, I'm trying to remember the past history, but I think your husband came back to say, I want to abandon it. So I said, well, you just drilled it only a year ago, whatever it might have been. So
Okay.
this has an interesting history, and I believe it was about 4 years ago. So it could have been prior to us having language on additional wells.
Yeah.
Is that correct, Kristin?
Believe so. Yes. It shouldn't have been decommissioned. I don't know why it was decided on that, but it was. And we came at it with you guys and applied for the application and everything back in 2018 and went through this whole process and it was passed. So I don't know why we're here talking about it again. Because I have the paperwork, it says that it was passed by the previous building inspector and conservation. So shouldn't this be like, shouldn't it be liable? I mean, these things don't go bad, do they? Do they expire?
Yes. Yeah.
Kristin, now the one that was approved, and you said the building commissioner, it might be our sign off too, but a question, that permit you just showed us, was that for the well at 16 or 18 Prospect?
Oh, this is 18.
18, okay.
Yep, right here.
One on the plan that Daryl had up, which I don't see anymore.
Oh,
Oh,
it's
I
not
can't.
showing?
Oh,
Oh,
here.
sorry.
There's a, let me see.
Is there any way you guys can flip that?
I don't think so.
And make it bigger, Daryl?
Yeah.
No, I'm on.
Okay. But that looks like an old one. to me.
Yeah, if you see where,
I
can
can't-
you, there,
Let me see.
all right, there's 3 wells that are shown. Okay, there's the one for 16. If you look at that long line, it comes in the middle and then there's a bunch of 2, 3 little lines off of it. Yeah, the one in the middle of
Yes.
that, where all the lines interconnect, that's the one that was decommissioned.
Okay. So why? Oh, the one right next door to it, you mean?
Yes.
Right, that one was decommissioned, and in October 3rd of 2018, they did get approval to reopen that well.
Yes.
I can read you the minutes
Okay.
from that. It says the agent presented the plan noting that the owner lives at 16 Prospect Street and previously bought this property so he would have more land. The
Yeah.
house was demolished and the well was decommissioned.
Mhm.
The owner now wants to reopen the well that was previously decommissioned.
Yeah.
There are no setback issues. In
Yeah.
response to a question, the agent stated that all testing requirements for both quality and quantity will have to be met.
Okay.
The agent recommended approval of the plan as presented, and such a motion was made, seconded, and approved. So it was approved. But
Yes.
now, then if you follow the line down to 16 Prospect Street, the well on 16 is shown.
Mhm.
Yeah, right there.
Mhm.
But if you go down a little bit from the existing well that was decommissioned, you go back, Daryl,
Oh, go back to where?
go up to the middle where the decommissioned well, and then you go down just a shade. It says new well. This plan was submitted because they don't want to open the old well. I guess the well driller said there would be a problem or something.
Mhm.
And they want to drill a new well instead. So that's what this is for. But it's an additional well because there's nothing on that property.
There's
So
actually about 4 wells on the property that were decommissioned. Because the property's so old. I mean, it was all farmland. That's basically what we're trying to do.
Can I just ask a clarifying question? So Ellen, I just want to make sure I've got this right. So before the regulation change, we voted to allow the undecommissioning of the well.
Right.
Subsequent to that approval,
Yeah.
we
that's good.
we have a new well drill application. So
Right.
the question I think becomes, the purposes of the regulation at least, is the difference between decommissioning a well versus drilling a new well meaningful in terms of whether it's grandfathered into the old regulation or not? I think is one question, and what have we done in other instances that are similar? And then I think all the points that Daryl and Lisa made are incredibly apt, which is just, we think that it's important for a number of reasons to minimize the number of wells we have, both for groundwater contamination and for patterns of use that could have unintended harms. That I don't mean to take away from, but I just want to make sure we're clear from a regulatory standpoint whether we believe that we've sort of thought about that issue. Does that make sense to folks?
Yeah.
That is correct. Yeah, that was a good history, Ellen. And indeed, what happened was our regulations changed through the request from the homeowners, from Kristin and her husband.
Well, I'm still confused if the approval was for reopening the decommissioned well and now it's changed to drilling at a new well, or
Yes.
is it still to just open the decommissioned well?
It's
No.
to drill the new well. The new
Okay,
well
because,
is the
right, so what we approved before, even, that preceded the regulation, was not drilling of an additional well, it was reopening a formerly decommissioned well, and now you're actually proposing a new well at a new location. Is that just?
Yeah, and I think what happened, Lisa, is what the well driller has indicated is it's probably got bentonite in it, and if they try to re-drill through it, and I'd have to get the expert opinion from the well driller, they may smear the fissures. With that said, I guess, as the homeowner has indicated, as Kristin has indicated, they still want to attempt to get water from this property.
Yes.
And that's why they were told, don't re-drill this well, drill a well near it, so it'll be a clean drill versus drilling into an abandoned well.
Right, but I guess it is different from what was discussed prior to the regulation being in place.
That is correct.
So,
that is correct.
Right, so I guess I just want to, just say it's not that we approved something and you just delayed doing exactly what we approved. You're actually modifying the plan somewhat, and it's in an era after we've already passed a regulation that changes the landscape. So
My question is when was that regulation changed?
It was promulgated, Ellen will have the exact date. It was in 2019.
2000.
Yeah, around April of 2019, roughly.
Okay, so still, I'm still kind of, guys, like, if this has been signed off 2018.
Well, no, but I think that you're being imprecise in the language. So if you want to redraw through your old well, that plan was approved and would be allowed. The plan before us is drilling a new well. That is a new plan. That is a different plan. And that would not.
Here, let me just cut you off. Right here, it says re-drill or repair a well at 18 Prospect.
Right.
How is that any
Right,
different?
but
You're not proposing.
Right now I'm looking at the plan that says new well.
Okay.
And so that's not the same as drill, like the minutes describe what we determined, which was going into the old well. And so if you'd said, hey, we're going to do either of these two things and we'd approve that, we'd be in a different position today.
Okay.
But I think that piece says it's going to the old well. One question I have for you, Mark, is can you just describe a little bit what the issues with going through the bentonite are?
Yeah, typically bentonite will expand and seal, and that's what they use it for in wells. And so again, I'd have to have the well driller explain why they don't feel drilling through the abandoned well would be sufficient. In my view, I think that's probably what they're going to come back with is when they go to drill, they may be smearing the fissures that produce the water from the leftover bentonite that they're drilling back up. So, but again, I'm not 100%, but I have a feeling that's why they proposed the new well.
That makes sense
Bentonite,
to me.
oh,
Yeah.
sorry.
Yeah.
Bentonite is a clay-like material, so
Mhm.
it'll swell with water and get sticky, and that's what he's referring to, the smearing.
Okay. All right. So our best bet is to go back through.
Well, so I guess I would love for us, it's just tough not in the room to kind of read the room a little bit, even with the camera. I would like us to just kind of go through for the board to kind of say, where are you at with it? I would say for myself, for me, from a regulation standpoint, the plan proposed is different than the plan approved previous to the regulation change. At the same time, if the well driller said from a quality of water or other pieces standpoint that the new plan is safer or superior to the old plan, then from my standpoint, I would want to do the better thing, even if it's not what I actually, like, I don't want a second well, but if there's a logic behind it, then, you know, that's not the hill I would die on. Lisa, where are you at? I know you did a ton of the work on the well stuff.
I mean, frankly, this is exactly the situation we were trying to disincline people from pursuing. And I feel like this case is a little odd in that, you know, there was this history that we just described, but I would say that what is now being proposed is not what was discussed and approved at that point in time. And, you know, I would think we would need to maybe think about it, but I'm pretty frankly very pro conservation and concerned about, you know, people installing wells for the purpose of irrigation only, and just with so many people having potable supply issues in the town that I'm nervous about going back on the regulation, which we instituted for a reason. So.
And Lisa, if I can add to that, I think what I find in most cases is once the new well is drilled, and usually you get good quality and quantity, the homeowners realize why the Board of Health goes that route. Basically, at that point, there's that comfort level to know that they have enough quantity to handle their needs. Might it be irrigation, might it be for the domestic use in the house or yard irrigation, but it is, we've seen it before where homeowners feel, oh, well, it's good to have a backup, but the problem, once you have a backup, it gets forgotten. So that's why I think I think the appropriate thing is to drill the well, see how it produces quality and quantity, and require the old well be abandoned. But if it doesn't produce the quality and quantity, then the board could readdress it.
Wait, but when you say it doesn't sound like, maybe Kristin, am I misunderstanding, but it didn't sound like you were planning on abandoning the well that's currently on the lot with the house.
Like I said, there's 4 lots on this property. It's the recent one that they just decommissioned was the one that was previously being used for the house that was there. You know, I think my best bet is to talk to my drill team and go from there and see what they're professionals in this. I can't really comment on what to do, the best thing to do. I do want good quality water, and let's just go from there, I think.
Okay. And do you have any issues with the well that's currently supplying your house?
Not currently. We did what did we do? It is having, nope, everything's fine, actually.
Oh, okay.
Yeah, everything's fine.
Okay, so then I could see why you might not be inclined to drill a new well if you're already satisfied with what you have.
That's not what I'm saying. When I first started speaking with you guys, we're not satisfied, and that's why we're proposing another to redrill.
But I think your point is you're dissatisfied with the circumstance on the property as opposed to insufficient residential flow for the existing home.
Yes,
Okay. And so
I believe. That's something I have to discuss with my husband.
that's on. So going back to, I think, the other clarifying question,
Mhm.
just so I think that you can have guidance with your driller.
Mhm.
Mark, am I correct that the existing plan, if they pursued it from October of 2018, would be approved and could be pursued if they were so inclined? Is that correct?
That is correct. I don't believe
I-
there was an expiration dates.
It would
Ellen, help me out.
expire, it would expire October of 2020, this year.
That's what I thought. They have the
Okay.
2 years.
So I would say it's a crazy year, obviously. So,
Yeah.
but I would say, like, I think that going back to your question for the plan that was approved, even though the regulation has since changed, that plan could be pursued under that prior approval. What I would say is, I think if you talk to your drilling company and there's some other set of considerations, it says the plan I'm doing that was approved is actively worse for the goals of the Board of Health
Okay.
than drilling a new well. I think that becomes really relevant new information to talk about, to
Okay.
kind of say, I can do this thing. I would like to do this thing that's better than the thing I'm allowed to do, is a different scenario than I want to do something different than what was approved, because I think that all the considerations that Lisa described are totally spot on. But
Mhm.
at the same time, like, you did get the prior plan approved
Mhm.
before the regulation changed, and that's valid for another 7 months, 6 months now, I guess.
Okay,
I'm
And
and I also, oh,
Go ahead,
sorry.
Daryl.
interested to know what the details, what are the risks of
Yeah.
drilling through the old well? Are there environmental or personal potential health hazards
Yep.
incurred? Would it potentially affect the quality of the water or the quantity, et cetera? Because I think that's might influence, that would be important for the board.
And if I may, and Daryl, go ahead. You were ahead of me. Go ahead.
No, you can answer that one, and then
Well,
I'll.
and what I would say is this, is that I think Kristen's going to be doing the right thing by getting back to a well driller. What they may be able to help you with, Kristen, is to tell you if the present well you're using for your domestic use at your house, they may be able to tell you if that well is at the point where you're better off putting a new well in. It's almost like, you're trading in a car in a way here.
Yeah.
And, do you really need to? And they should be able to tell you that. And if they feel that you can get, better quality and quantity, and the quality is just as important, they'll
Yeah.
be able to tell you that. And they may require you to, or ask you to do a couple quality tests just to see how
Okay.
your existing well is performing on quality basis, not just quantity.
Okay. Sounds great. I think that's a
Okay.
plan. I agree with all you guys. So.
So another question is,
Mhm.
if you were able to drill this new well or even re-drill your currently abandoned well, what would it be connected to?
I'm not understanding the question.
So you have a well that's connected to your house,
Mhm.
but what would this other well be connected to?
It'd be usage for 18 Prospect Street, mainly.
And,
Mhm.
but how would it be used? What would it be? Is there a barn there?
Yes, it's a barn there currently. Yes. Mm-hmm.
Right, so, and currently the barn is not connected to the well that you have?
No. Mm-mm. We are supplying, like I said, lawn equipment, stuff like that, and just looking to reconnect it and use it for the property. Mm-hmm.
Okay, and is the barn this, like this faint outline over here?
Let me see. I can't see the map. I'm not too sure if this map that you guys are all looking at, if it's the updated version of the plot, because I can't really see it.
Oh, sorry.
It's okay.
Unfortunately, I have not, I'm a WebEx person. I'm not a Zoom person, so
Hold on.
can't
Yeah,
quite
this is-
manipulate this the way I'd like to. All right, so you have a barn over there, and it
See.
is, it looks like it would be, if I'm looking at the right thing, maybe half the distance from your new well is from the old well?
Well, I think what we're dealing with too is gravity. This is on a large hill. Down the hill is going to the existing well for 16.
Okay.
18 is up on top of the hill where the barn is. This is the structure of it. It's kind of like hilly. And then 18 is up on the hill where the well previously was. So I don't know if that's a factor in play with this whole thing. Reopen it, like to reopen it, I think it would help because of the gravity factor, because as we all know, plumbing is easier coming down than up. But yeah, that is a barn over there, the
Okay,
large square.
okay. All right, and there's a hill in between.
Yeah.
So in
There is a
between the
large
house and the barn is a hill. All right, okay. Okay, right, I would say I'm in agreement with what Lisa had to say, in that this is a new well, is a whole new application and consideration, and we're not enthusiastic about that. So
But if it's already grandfathered in, I don't understand why,
the well that's
Alright.
there, sorry to split hairs on what's there and what's not,
okay,
but it is what we approved. And, you know, sometimes regulations march on
okay,
and evolve in new ways. So we did approve something else, but it was for for the well that's there.
okay. So that's something I'd like to just discuss with my, my drill team. And then do I come back and say, let's have a meeting again? Or how does this gonna work?
Yeah, it could be. And it could be a consideration of whether the new well might offer enough to supply the home and the barn.
I think she's asking sort of the concrete question of, my sense is that despite our wonderful articulate argument, I think that you still are kind of interested in something different than we might pick if we were in charge. And so I think the next step for you would be talk to your driller. You could regroup with Mark. It may or may not need to come back to the board as a whole, depending on what that conversation involves.
Okay,
If it's going back through your previously approved plan, then there's nothing new that we need to approve, even though we would encourage you not to pursue that because we think it's a bad idea. You are
okay,
totally allowed to pursue it because this is America and people can pursue bad ideas. And if you say, boy, here's the compelling reason that my driller provided why pursuing the previously approved plan is actively more dangerous to either myself and my family or to the water supply that this is part of, that would be a place to bring it back to the board as a new fact that you would then say,
okay,
this is not an approved indication. This is not approved with the regulation, but it's better than the alternative that would be pursued without some alternative approach. That would be the context I would imagine coming back to the board. Does that sound right to folks on the board?
Yes.
Yes.
so would you guys, now through my well team, I would hope, not hope, excuse me, I would like to I'm gonna get the water tested and everything like that, and then decide from there what we'll do. So yeah, you're right.
Okay.
If you're doing what was previously approved, then you don't need to come back to us because it was previously approved.
Thank you.
Yeah.
Okay, I got it.
Thanks.
I think I'm a little stir crazy in my house, but you know, we got to do what we got to do. So
Totally know the feeling.
yeah, I don't think I've done this many puzzles in my life. Oh boy. Okay, so let me get a hold of them and I'll decide and let them know.
Okay. Great. Thank you.
Thank you. And I hope everybody stays safe and clean and it doesn't get too crazy out there.
Awesome. Thanks so much. You have a good night now.
You too.
And
Bye.
Kristin,
Yes,
feel
go
free
ahead.
to call our office, Kristin, if you have any
Thank
questions.
you.
Okay, thank you. Bye, guys.
You're welcome.
Bye.
Bye.
Okay. So Rebecca, you had something that you wanted to.
Oh, I just wanted
Back to COVID.
so you were talking about assuming people have COVID-19, and I was going to say that there's a subtle distinction. If a patient has a known contact or a household member who has COVID-19 and they're symptomatic, those are the patients we're assuming are positive. But if a patient just has symptoms and are URI symptoms, but there's no known contact, those are not assumed to be COVID-19. Those are referred for testing.
Okay.
No, they're
So-
not. They're
Make
not.
sure.
My daughter's a perfect example of that, Rebecca. She came through New York before she came home on the 16th. She had a cough and like her throat hurt and swollen glands. And I was like, you got to call your doctor. And she did. And she went in and she got tested for flu and strep. Both were negative. She lost her sense of taste and smell, which is a completely unique COVID-19 symptom. They said just self-isolate and we're not going to test you because her symptoms were mild. And she's
I'm telling you the Newton Wellesley Hospital protocol, and it's possible that if you called the COVID-19 line, which is being regulated by DPH, then you might have a different.
No, her doctor's at Newton Wellesley. She went to her doctor at Newton
Well,
Wellesley.
it's not going through the PCPs. It's actually going to the COVID-19 line.
I don't think that's uniformly true. What I would say is, I think also, like, at least the inpatient testing criteria have been updated several times. So I think some of it depends on when you're there, but I would say broadly speaking, I think like we are not routinely testing outpatients right now who present to like if you don't need to be admitted, you are probably not going to get tested.
Yeah.
Just because the testing availability and then also the PPE required to complete testing isn't trivial. So I think what I would say is for folks who are sick and need to be hospitalized, they should totally seek care and we'll take great care of them. For folks who are kind of...
I'm only referring to assuming that it's COVID-19. Based on... That's all. It was just about assuming that it's COVID-19.
I know, but both her physician and 3 other of my doctor friends said absolutely we should assume and treat tests like she has it, including her doctor,
definitely
without getting tested.
That are appropriate for that assumption. So I can agree with them.
Right. So, but she's not atypical. So I think there's lots of people who have the symptoms, but they're not bad enough to get admitted to the hospital that aren't going to get tested, but should still be treated as if they're positive. I think that's a cautious and smart thing to do.
No, I'm not disagreeing with you, Lisa. I'm only pointing out a very subtle distinction from a statement that Daryl made earlier. If a patient has URI symptoms, we're not assuming that they're COVID-19. If they have symptoms like you're describing that meet the diagnostic criteria for COVID-19 situation. That's all. I'm just talking about information from Newton Wellesley Hospital daily staff meetings, and it's changing on a daily basis. And maybe when you talk to your doctor, it was different.
And Daryl, do you want to kind of do some of the other updates? Because I don't know if you've done a ton, I know.
All right, hold on a second. I have to bring up those notes for me. Let's see, I've lost track of how many meetings Ellen and I attend each week.
All of them.
A lot.
Yeah.
Yeah, Ellen, can you still tell that you're part-time?
You're right.
Good one.
You only work the part that you're awake.
Yeah, which isn't often.
So anyway, I will say that the interdepartmental town meeting, which is really being called the Sherborn COVID-19 work group meetings, are with just to refresh everyone, the fire department, police department, council on aging, DPW, select board, health, and various others probably coming in periodically. So, you know, we're always discussing things like PPE, which Jeff was mentioning at the beginning about getting more PPE for the first responders. So that should make things a little bit easier, dealing with staff being quarantined and out and how to address that and where they get housed and keeping up with the latest. So there are spaces being procured by Framingham and Natick for when first responders are exposed and need to be quarantine somewhere for the safety of their families. So that has been arranged. We don't know yet if at some point that will be insufficient, if things really start to climb, but we'll just have to cross that bridge when we get there. It's hard to summarize all the things we talk about. We talk about messaging a lot. We've been trying to improve the website. We've been reaching out to different groups. That's gone pretty well. The part that we're wrestling with the most now are the folks who still congregate in groups, and they are often teens and others. It's not only teens, there are also adults who are doing it. So when things have shut down, people often note that there are streets lined with cars as people all get together at someone's house or meeting in parking lots and fields, places, although most of the fields have been, at least in Dover, have been shut down. So the bigger fields at the schools and what have you. And that we're just looking for a way to do it. We certainly speak with Andrew Keogh, who's the district superintendent of the schools. And with classes going to be starting up soon.
No, it's gone through May 4th at least.
Well, they're working on how to do online classes.
Oh, yeah, but they have to do it for the whole state, so it's gonna be difficult.
Well, yeah, there have been a lot of different messages being sent to the schools. So part of, I think, what we spend all day, every day on is just trying to keep up with the myriad of changes. So they were initially told, don't bother with trying to continue classes. Then they were told that even if you did it, it wouldn't count because it wasn't a pre-existing system for delivering classes online, and it hadn't been approved, so why bother? And a few other iterations in between, and now it's up to they're having teachers at the schools go into their classrooms on a schedule so that they're staggered, so that there aren't a lot of people running into one another there, to pick up the materials that they need to then bring back home and be able to deliver some kind of classwork remotely.
Yeah,
So
I mean,
part of that, I think, is to have some sort of normalcy and continuity. And a lot of things haven't been resolved on, they're still arguing that there shouldn't be MCAS. I think a lot of the superintendents of schools, but the state hasn't approved that yet. So that's where they are, but that might be a venue for messaging.
Yeah.
Is they were talking about maybe having a group all school meeting in the morning, first thing in the morning, and maybe delivering some messages.
Because I talked to someone on the school board, and I thought that what the state had been saying all along is that unless all the public schools in Mass, have equity about and access to learning new material, that it was inappropriate on a district by district basis to learn new material. So, because especially an issue for, certain areas in the state, in the city, that not everybody has access to Wi-Fi and computers, that that was an issue of concern that I thought was prevailing, but maybe they figured out a way to deal with that.
No, it's very complex, Lisa, because you obviously also have SPED students who are on IEPs.
Yep.
So even within Dover Sherborn schools, there's all kinds of assistance provided to students in the classroom environment, including some intensive ones where they have, aid in the classroom. So it's very complicated.
Yeah, I agree. I mean, I think it would be great for the kids, though, to have something that, whether it be like lesson plans that can be emailed or something that because I know parents with young kids, it's really, sorry, Matt, that's you.
No, I would say I've been really impressed by what the school has pulled together and how quickly they've done it in terms of, both just having some structure for my second grader. And then also like getting feedback and coaching, like it's definitely like this whole experience globally has been fairly miserable, and I would prefer to not have any more pandemics. But I've been really impressed at the degree to which the school has pulled stuff together and the degree to which our teachers continue to support our kids has been awesome. Although
Great.
nothing makes me appreciate the Pine Hill teachers more like having my kids at home, because I have no idea how they do it.
Awesome.
Like if they need to renegotiate the teacher's contract, they should definitely do it like August.
I think it just got approved, by the way.
Oh, perfect. Then
Or
that's
it's in
good.
the works. That's what I
That's
heard.
good. Yeah, because
Yeah.
boy, do I appreciate them right now.
Yeah.
So on a minor way, I still am chair of the Boy Scout troop in town. So we're actually still approving merit badges. I'm signing off on, and you've probably seen the video of Sherborn, the drone video that
Oh, that was awesome.
Andrew Gillette. I'm signing off tomorrow on his Eagle Scout application.
Yeah, that was awesome.
So we're still, we may even have a number of them. You have to get one of the merit badges, citizenship in the community. A number of them may participate in the select board tomorrow night and ask questions. So we're still doing merit badges and everything online and signing off via, printing something out and signing it and then scanning it and sending it in to the council. So we're still keeping the boys, these is only for boys 6th grade through 12th grade, but we're keeping them actively engaged also.
That's great to hear. I mean, I think,
And they may be delivering food. They may be helping Sue.
oh, that's great. I think one thing, Daryl, I really appreciate that the town of Sherborn has kept open the town forest and like Barber, because people's mental health is just as important as their physical health. And with all of the social distancing in effect and the removal of tennis courts, fields, and the school track, etc., outlets and gyms being closed, that it's really important that there still be safe but access to outdoor trails with dogs or a hike with your kid or something. So I'm really hopeful that we can keep at least that open.
Right. I mean, I agree, and I've been pushing for it all along. And that we just posted information and help people learn the behavior rather than just prohibit blanket in a blanket fashion something. That is being handled very differently in Dover. So.
And I think, I think the issue is the congregation has been a really big issue, and I definitely saw it before they closed trustees. I was coming home from work that weekend, and you're like, there's cars parked all the way up the road. You see like groups of like 6 and 10 people standing, talking to each other with their dogs, hanging out, which is totally lovely. But it misses the point that this is not just a beautiful weekend day, that like there's a reason everything shut down. And I think especially for them, I think at Carroll, they were having a lot of that, and at other places. And I think that was a concern for the school fields too, is that people were like coming together for pickup games and other pieces. And it was just this concern of like, we really have to send clear messages. And I think people are really used to like, it's a beautiful weekend, I'm gonna go do this normal thing. And we're just not in a normal time. But I think that the nice thing for a lot of the Sherborn, like I think Barber is honestly the trickiest one, but a lot of the other ones are pretty small scale and pretty light footprint. And I think that makes it easier than like Carroll.
Right, and that's part of, we have posted at our fields, no contact sports, no using of shared equipment. So there's an attempt to address that. And as they've seen in Dover, people have just moved elsewhere, and the trustees were certainly seeing such massive numbers of people coming at once that they couldn't even separate that easily. And people start to forget, seems like nice to be out and friendly.
Could whoever's on like stacking dishes put themselves on mute?
Either that or make dinner for us. One of the choices.
Can someone, whoever's making that noise, can you put yourself on mute, please? Thank you.
So can I add one thing, Daryl?
Yeah, go ahead.
Or you can do it when you want. I don't want to get your flow.
Oh, just on that, I mean, it's something I'd love to think that we could work a little harder. I even raised with Andrew Keogh whether, but it would take Dover being in agreement, whether we could intentionally have activities with kids at the fields where they stay separate so that it reinforces what this is supposed to look like. And I think the police in Dover have approached groups and asked them to break up or separate them, do the physical distancing. When I checked with our police department here, and they just haven't encountered a lot of situations, but I certainly hear from people talking about their neighbors having a group of kids over in the backyard all close together. So we still have a ways to go. It's a little mystifying to me that, I mean, it is and it isn't. People don't want to follow this because they're not perceiving it as a direct impact on them, but it will be at some point, so, or it could be.
I mean, I think Massachusetts, though, the compliance rate as a state is so much better than so many other states. And like a peer of mine at work, his daughter was a student at University of Florida, and they live in New Jersey, and his wife and his daughter had to drive straight down in one day from New Jersey to Gainesville, pack up her dorm room because they were one of the schools that was on spring break, and then it was like, yeah, don't come back, but then at some point you have to get your stuff. And they were stopped at the state border by Florida cops and had to say, explain what they were doing, which they approved, and then they let them in, and then they had to come back. But meanwhile, all the restaurants in Florida were open. So.
Carol, are you able to
Yeah,
mute the
I'm going to
lines
try.
as the
Well, I think all you have to do is close out of it, too.
It's JM, whoever JM is, that's what's
Can you please
making
mute
noise.
yourself? Just click
No,
the
I
microphone.
Carol, you can mute.
Yeah, I
Jim.
can mute them.
you can mute them centrally. That's power.
There you go.
Wow. That's handy.
Thank you. So anyway.
My wife's been looking for that button at home and she has not found it yet.
Yeah.
Good one. But I think our website is a nice amount of information, and like I said, it's a balance between educating people and providing resources, but also not overwhelming them, because that's when I think people stop listening. It's almost just a disincentive, like when you get too many emails, you just sort of just delete them. So I think it's important to have that balance. And I also don't think you want to make people so fearful that it's, we're getting into an anxiety situation and overload just as a society. So I think it's a pretty good balance what we have right now.
Okay.
And
So
I would,
actually, Matt, are you?
and I would also just commend you, like you guys have done between, I think, Zach and the Dover board and you and Ellen have just done an enormous amount of work for that. And so I just would pause and say thank you.
Yeah, applause.
Thank you. Thank you. So Matt, on the hospital side, are things still on the steep climb?
So what I would say, so I think I can speak in generalities mostly, but I think there's enough details in there that it can still be helpful. So what I would say is, from a preparedness standpoint, there's been an enormous amount of work across all the hospitals to try to kind of create capacity and to look at the epidemiological models that they're using for the state, as well as internal modeling, to kind of figure out what are we going to see, when are we going to see it, and how do we get the tools we need. So I think that part has gone well. I think there's been significant variation across hospitals with how many patients facilities are seeing. So for example, Mass General has seen more patients than we have so far, but I think over time, a lot of that will even out. I think from a capacity standpoint, right now, I'm not aware of any hospital that's kind of up to the gills yet. I think that across the board, there's some capacity. I think that the big things that I think all the Massachusetts hospitals, or at least all the Boston hospitals I'm aware of, have been very appropriately aggressive about decreasing elective procedures and other pieces, both to preserve resources and to preserve capacity. So I think that they've, again, I see my own shop the most, but it feels like it's being taken extremely seriously and they're doing everything possible. I think that there's definitely a lot of disruption right now in terms of kind of access for other things. I think there's some populations that you kind of, like when they talk about the psychological challenges, I think there's some patient populations where it's particularly challenging. One of the populations I've heard about a fair amount is our patients with cancer diagnoses, because it's sort of already scary and challenging and really a different piece. And then you overlay that with this kind of disease that has particular risks for people who are in a higher risk category. I think that's been hard. And I think those also can often be the procedures that are not emergency procedures, but nor are they elective. You kind of can't say, I'm going to put off a mastectomy 3 months. And so I think that balance has been challenging, but I think has been well managed. I think Barbara's doing an awesome job with a lot of it. So overall, I think we're in the phase where it feels a little bit like the calm before the storm. We're still at my hospital at probably 30 or 40% lower than typical census, although I suspect that in the next 2 weeks, we'll sort of get back to normal and then some, just with the cadence of how this typically rises. I think the other thing that's been described out of New York and Seattle is that, especially for the critically ill patients, it's a pretty long course. And so if you do have people who get sick enough to need an ICU and need a ventilator, the amount of time that they need it for is a couple of weeks. And so I think that what we'll see is that the critical care capacity and the ventilator capacity will be challenging, which I think is, what they've seen in New York and in other places. I think we are the kind of last model I saw for Massachusetts, and there are a couple of publicly available ones that you can kind of say, what does Massachusetts look like? What does Maine look like? What does Vermont look like? That are out there that use publicly reported data. Massachusetts is kind of in the middle range of kind of how busy we'll be relative to how much infrastructure we have. I think that it's still hard to know, we sort of see like what's unfolding in New York is, pretty awful in every sense. And I don't think that we necessarily expect that we'll get to that point, but it's a piece that you worry about. And, there's a lot of connections between kind of Bay Area and Boston and New York and Boston in terms of kind of healthcare relationships, or where people kind of train or where people move after they finish training. And so you definitely hear from people in New York and it just sounds exceptionally busy. And so I think for me, my take home is just everything we can do that is balancing that tension that Lisa describes between letting people have chunks of normal to manage what will likely be a prolonged period of challenge, while trying to be aggressive everywhere that we can be aggressive to kind of flatten things out and give us more time, will be hugely helpful. I think PPE access has been challenging across the country. I think it's challenging in Boston. I think that we are better off than some areas, but are still, like, I haven't seen stuff like this before, although I think the hospitals are all working incredibly hard on it. The PPE access is tricky.
Matt,
Yeah.
you have anything to say about heart disease patients?
So definitely, so I'll talk about heart disease patients, but I won't say they're like you, because I think it's definitely, there's a couple of categories that they've described as having pretty clearly elevated risk. So diabetes, heart disease, and I think chronic lung disease are 3 areas that have come up a fair amount. I think that the other thing that's been interesting with COVID is I think there's been a fair amount of cardiac complications that have been noted, although I don't know how much those correlate with underlying heart disease. So there's kind of been some cases of cardiomyopathy, meaning the heart is working less well as a pump. that's sort of virally mediated. But I think that when they sort of look at the big buckets, heart disease is definitely one of the elevated risk buckets. And so again, I think those aggressive social isolation strategies, things like grocery delivery, I think help, and kind of minimizing the risk. I think that, the part that's hard is that the testing is so skewed that looking at the testing we have available in real time has a lag in terms of how people do. So whenever we're in that really steep vertical part of the curve, when we look at it, that outcome data is really limited because people haven't had time to get to their outcome yet. So if you're like, we've got 180,000 cases and we've got this many of this outcome, if we had 40,000 cases last week, then 140,000 of those cases haven't had time to get to their outcome yet. And right now our testing has tended to be very focused on sick people. And so that subset of people will tend to have a worse outcome than the whole population. So I think we said this maybe 2 meetings ago, like I think the data out of South Korea is probably more informative in some ways than our own data because they've got a much higher testing rate. And I think the data from there has been markedly better. I think when you look at the mortality data out of Italy, it's significantly worse. But when you look at the demographics of who's infected, a lot of that has to do with Italy's one of the oldest countries in Europe. And so the proportion of patients who are older is really high. And that's where the serologies, I think, will be helpful. But I think that by broad strokes, like heart disease, cancer, diabetes are the ones that have come out so far. And there's some question about kind of chronic underlying lung disease when they look at some of the gender differences. One of the hypotheses is that it's patterns of previous smoking. Although I don't know that we know that that's true or not. I think that's one of the things they posited when they saw the outcomes in China in terms of the male mortality rate was significantly higher than women, like something like, well,
it's 215,000 right this minute.
Oh, for the US, yeah.
I mean, it's the last time you looked, it's gone up by 20,000.
Yeah. And I think that, for us, like, when you sort of look at the projections and you sort of say, okay, if they say there's going to be 100,000 people, 100,000 deaths, if we sort of look at what that is, if that's 2.5%, then, we're going to be looking at a lot of infections. But I think the part that makes me feel hopeful is just that I suspect that what we're going to find at the end of this is that, or hopeful is probably not the right word. What I wonder about is that when we look at the big population modeling and they sort of say, this is how many things we'll need at X, Y, or Z point, what I don't know is if you have significant asymptomatic or minimally symptomatic infection, then when you look and say, boy, we'll have this many people infected and this is what it'll look like. If like a significant fraction of our infections right now are not captured, then some of those things may look different at the peak in the worst case scenario. So I think that the truth is somewhere in between CNN and Fox News. I think that this is a truly devastating pandemic. It will be profoundly disruptive in a lot of ways. I don't think it's going to be the end of the world, and I think that we'll get through it in some period of time. I think that getting the ventilators will be one of the critical pieces in terms of minimizing the risk of mortality if we get more pervasive infection, because where the numbers really start to spike is when you say, boy, we've got 20 people who need vents and 10 vents, or they've actually done some stuff in New York and Italy where they're now having 2 people on a single ventilator. They've kind of developed a splitter, and I've heard that they can do it up to 4, though I don't know that we have plans to do that in Boston. But kind of building that ventilator capacity makes it easier to get through illness without having a big spike in mortality. And then I also think there's some rapid cycle testing that has been approved. I don't know how widespread its use is. I think one of the assays I heard was about 45 minutes. I think that's from Abbott. I saw it in CNN the other day. And so as you start to get really rapid cycle testing, it also changes. That if you can get that more widely available, there's a lot of stuff that becomes more reasonable to do. If you can say, hey, we've got this screen, we know an hour from now that you are COVID negative, that's really different than our current environment. And so I think that's the other thing that could have both an aggressive public health strategy while having liberalization of the things we're doing in the moment in terms of having businesses able to reopen or to do other things.
So I asked to have the mask issue put on the agenda. Anybody want to talk about it?
Yeah. So do we have a, sorry, I had that listed somewhere, but do we have a motion to add masks to the agenda?
So moved.
I figured it came under this discussion.
Oh, yeah, that's
Yeah,
fine.
I don't
Thank
think
you,
we
Ellen.
need to
Thank
have
you.
that. Yeah.
All right, never mind.
I just wanted to raise it to see if anybody wanted to talk about it besides me.
Yes.
Which aspect?
Well, there's confusing information and contradictory information out there, especially from the CDC, which reversed itself today over yesterday, over whether the general public, people like me and you, who are asymptomatic, should wear masks as a means of either protecting others from what Matt was just talking about, the pre-symptomatic community spread problem, or protecting ourselves if we're in a high-risk group, okay? And
so
that's the question.
Yeah, so what I would say is I think we've seen a bunch of evolution for this. I think that what we're doing at my hospital right now is that everybody who's in the hospital has to wear a mask all the time. So you're sort of in a mask constantly. Most of the time that's a surgical mask. If we're doing an aerosolizing procedure, it's an N95 mask, with the difference being that that's a tighter fitting mask that's protecting against airborne kind of pathogen, where the surgical mask is protecting against droplet. I think the data supports that surgical mask usage for patients with a droplet-based disease like influenza or COVID can be helpful to reduce the risk of spread. I think that there's ongoing discussion about the degree to which COVID requires an N95 versus a surgical mask. I think many of the hospitals in Boston and internationally are using kind of a regular surgical mask. The idea of that is that the droplets are bigger, and so you don't need to have something that's as tight fitting as an N95. If you're doing a procedure like intubating a patient or using some of the respiratory supports we use in the hospital, that act can turn this from a droplet disease to an aerosolized disease, because you've got air under pressure that's kind of aerosolizing the patient's secretions. And so that's the logic for needing to use an N95.
Yeah. So Matt, what I'm asking about is, should we, the Board of Health, put something on our website encouraging people to wear surgical masks, not N95s, so you can't get them and you can't make them, either surgical masks or homemade equivalents, which is what I've been manufacturing and gearing up to make a lot more? Or should we just be silent and let do whatever?
I would be silent for a little while longer until we get clear guidance from the CDC. I suspect that we'll end up seeing that there is some recommendation to do this, because I think we'll see that there's more asymptomatic spread than we've identified. I think that some of that's balancing against, if you're doing everything else, like if you're self-quarantining at home, you probably don't need to do a surgical mask. You know, there's no upside to that. But if you're saying, I'm going to go pick this takeout up, there may be benefit to doing that, because if you're sick and don't know it, not getting the pizza guy sick probably helps dozens of people who may be at risk.
Right.
I think that, so my guess is what we'll see is something that evolves to sort of, here's the circumstances you're in, what are the cautions that are prudent? My 2 cents would be stay quiet a little bit longer until we get clear central guidance, because I think there's limited data on it now.
So can I comment?
But I don't feel
You're done.
strongly.
Can I comment when you're done?
Go ahead.
Yeah, fire away.
At today's staff meeting for Newton Wellesley Hospital, this discussion came up. And the first thing is, it's absolutely documented that wearing a regular old surgical mask will protect another person from anything you're carrying. And for that reason, it's probably beneficial for people to wear a mask, whether they know they have COVID-19 or not. And certainly if you're symptomatic, and whether you have influenza or COVID-19, there's a benefit to society if you wear the mask. There's no proof that right now the specifics are not recommended in a formal way. But if you're symptomatic, there's a benefit to it. The opposite side of the debate is what Matt addressed, where we're specifically referring to in the hospital, everyone is wearing a mask at all times at Newton Wellesley. For aerosolized generating procedures, everyone is wearing or required to wear N95 masks. For everything else, it's assumed that the regular surgical mask is probably sufficient to protect from both acquiring it from another person inadvertently or from you giving it to somebody else. The biggest problem is that the data, what we don't have is the information about the amount of time that COVID-19 stays alive in air and on surfaces. We know that it's been documented in a research setting to be alive or viable for 72 hours, but there have not been yet any documented cases of transmission from those viable particles. So,
Rebecca, you just made my point that you're saying in the hospital, you guys are wearing regular old surgical masks, not using up your N95s, and that's presumed to provide reasonable protection against inhaling the droplets, right? What I'm saying is, shouldn't everybody who's walking around out there wear whatever they can to slow down? It won't stop. It's not as good as a surgical mask, but surgical masks are pretty crappy, right? They have lots of gapping around the edges. I have them, I've worn them, and what I'm making is equivalent, maybe a little bit better. I just think it's crazy to not wear barriers if you can wear them.
My personal opinion is, yes, I think it's a good idea, and everybody, if they want to really do their part, there's probably a benefit to that. I think what Matt is talking about is whether or not the Board of Health should have a formal procedure. I think it's a good idea. I'm telling all my friends, and a lot of my doctor friends are telling their relatives and friends to wear masks every time they go outside.
But
I'm not wearing them when I run. I'm just saying it now.
Although the thing I would add to that is I think the shortage of masks for kind of PPE for healthcare providers is such that I would say people should really, if they're wearing that for personal protection outside of healthcare, I think my ask would be the masks that David describes that are homemade cloth masks, which are not generally ideal for healthcare providers, would be what I'd recommend people to use. And I think that messaging is important.
I don't think you have to worry too much about that. Outside of healthcare, you can't get one for any amount of money from any place on the planet. I know, I look. You can't even easily get the materials to make them. I just had stuff shipped to me from Los Angeles, which I paid a lot of money for, to make some new masks that have a layer of H100 inside. So they'll do pretty effective filtering, but they're not tight sealing. And I'm providing them to the Army because they don't have any friggin' masks.
Yeah, I don't know that we should start making medical recommendations that are, beyond what our resources are, because then I think there's just a host of issues that would concern me that we do that. So I think most people know that if they can wear something, then they should. And if they have the access to it, but a lot of us don't. And so then I think you're going to be flooding Ellen and people like that. Like, well, are you going to be providing them? How do I get access? So I think just relying on resources at the state level for information and like WHO and the things that we have on our website makes sense. But I'd be nervous about us making our own recommendation. That's just my 2 cents.
So this is along the lines of what I feel like we've been dealing with for the past 3 weeks or so. are all these uncertainties because there's not enough time, not enough data, not enough understanding, too anecdotal. So this is, I think, been probably about the harder part of this in terms of planning and knowing how to respond. And people do keep asking us to split hairs. Should I do this or should I do that? You know,
I think you guys have done an awesome job at sort of managing that, because I think the reality is the day, like even kind of going back to Rebecca's points about the daily staff meeting or email, like in a place where we've got people who are experts at thinking about this, it requires like a daily update to keep up, and it changes every day.
Yeah.
Because I think we're just learning a lot. And so I think it's okay for us to say, we cannot do the totality of what's out there because that is really hard to find. I think sticking to the stuff that's pretty clean makes a lot of sense. Social distancing is a good thing to do.
Yeah.
The strategies to support our older adults or other high-risk populations is a really good thing to do. And I think that the kind of social distancing stuff that we put in, whether it was the school or working with the churches or the COA, those are really good choices. And I think it's okay for us to say, hitting the things that are obviously right and focusing on those while possibly missing some opportunity that was potentially beneficial. It's okay for us to not hit all of them from the Board of Health standpoint. I think doing good work that's reliable for what it is, even if it's not comprehensive, feels like the right strategy, as opposed to pushing the envelope to maximize safety, if that might be beyond the data or guidance that people are getting from either federal or state government. It may be that that was a chance for us to get ahead of them, but it's going to be really hard for us to stay ahead of them as this becomes more active.
Right. And I would say I spend a large part of each day just searching for what new information is out there, not because I think it will have the answer. I'm just always looking for what is the range of ideas. What's the range of days of survival on different types of surfaces, and what is it that about the surface characteristics that affect it, and all of that kind of stuff, just so we have an idea. Because unfortunately, people are asking us, as I said, to split those hairs and give them the definitive answer. And in the end,
it doesn't
we do
exist.
boil down some of our responses, such as someone who wrote in about they were at the post office on day X. Were they exposed, and are they going to get COVID-19? So the answer to that was mostly, there is no further information. You should be behaving anytime you go out as if you are going to be encountering it. And you should, as long as you practiced your physical distancing and washed your hands and were careful about touching surfaces and all the rest, then you're doing the best you can do. So, but it is interesting that people want those answers.
I was just at Walmart. I didn't want to go there, but I had to. And I had my N95 mask on. I have 4 of them left. And there was another guy like me that had an N95 mask on, an old guy. And everybody else was acting like it's business as usual, which is frightening. And that's why I think that the estimates are wrong. It's going to be worse than they project, not better.
Yeah, it's disheartening.
And the store was pretty full. It was probably half of normal, but you know, there were a couple hundred people in there probably. So
Wow.
Market basket was the same, if that's any consolation to you.
no, it just confirms what I'm saying.
Yeah.
I don't think most people get it. And
No, I think that people really think I feel fine, so it's fine. And I think that, you know, people sort of feel like this is mostly springtime. And I think that my hope is that enough people get it, because we don't need everybody to get it to make things better. We need to get enough people to get it. And I think that's, you know, that's what I don't know that we have. I think what I've heard is that the data out of Washington and California seems to be that there's some benefit to their strategies, but I think that's much more aggressive than we've embraced so far. Although I think we made progress kind of in Massachusetts, but I think that it's still that balance for disruption versus safety is a tough one to get just right.
Yes, I was talking to a friend in Oregon who said she found a box of old masks in their basement from some kind of house renovation activity they had, was unopened, but 15 years old. And she said her nurse friend was so delighted to get this box of 25 masks that she couldn't believe it. But anyway, she's also doing the same thing with her husband, saying no use of power tools, because one of the things I try to talk to people about now is don't worry about whether you're going to get coronavirus. Worry about whether your appendix is going to burst during this time, and are you going to get the hospital care that you, in a normal period, will just assume you can get. And maybe that won't happen, this, or your kid breaks a leg or whatever else.
I'm going to choose to just worry about all of it. I'm going to worry about
Yeah.
all of it with the side of global warming. And then now that the mosquitoes are back, I'm anxious about EEE.
I disagree, Matt. I think you have to pick your thing to worry about, because if you try to worry about it all, your worry capacity will be overloaded, and then you'll have worry stacked in the hallways. So I'm worried about not getting it, and I'm doing other things that could get me hurt. But the point's well taken. I know if I call my PCP at Mass General, I won't even get her. So.
The problem right now is the inadequate availability of testing, and the fact that patients are able to transmit the virus before they're symptomatic. And ironically, we're not allowed to refer patients for testing unless they meet specific criteria, but they've already been spreading the virus before that. So I think that there are some very good points that are being brought up. And I think that this is obviously the reason that we haven't reached the peak yet. And so, but I mean, fortunately for the appendicitis example, those patients are the ones who are having surgery right now. It's the elective, mastectomies where maybe those patients are increased risk.
I'm talking about when our system gets overloaded, which we're not there yet, but
Not close.
may not be far. So
Yeah, I mean, it's frightening, but I think that are we only making recommendations once they've been officially made by our state at the state level?
no.
But we haven't made any, I would say, controversial, not in other numerous resources yet. And I think that's the way we should stay.
Yeah, but I don't think it's controversial for us to say, anyone who would like to wear a mask might have a benefit.
Well, don't you think people know that already? I mean, if you,
I don't know.
All I think, I do. I think that the people who are interested and concerned about it are reading. I mean, you can't help it. You're inundated daily with this stuff. Like every news feed, it's on it. And I worry if we start saying you should wear a mask, I don't have access to a mask, or if you have it, wear one. How come I don't have one? Am I at a much greater risk because I don't have one? Things like social distancing and washing your hands are probably the two simplest things that everybody can do, and also the most effective. So I think by hammering that, we're really keeping people focused on the most important things that they can do. And it's something that everybody can do.
Yeah, I'm telling patients to make masks and wear scarves, because they can, although they won't be able to filter COVID-19 if they're close enough, or if they come in contact with it, they'll actually be able to minimize respiratory droplets from that individual. So there could be a benefit.
Yeah, I don't think there is. I agree that I don't think it's not beneficial. What I'm saying is I don't know that we want to post that on our website coming from us.
I agree with Rebecca, but I see your point, Lisa, that it will stick a stick in the hornet's nest and stir up a lot of anxious people calling all around saying, where do I get my supply of masks that you said I should be wearing? And our answer will be, can't, don't
Right.
know.
Yeah. Ellen will be like, I've retired. Good luck.
Exactly.
God bless.
Yeah, bye-bye.
I'm gone. Jeff Waldron has all the masks.
He said he's getting 11,000 of them. Let's
A
talk.
craft idea for mothers with their children while they're stuck in the kitchen.
That goes back to the statement about whiskey earlier. Unless we're providing whiskey, there are no craft projects.
Okay.
Your kids have to provide whiskey to you in order for you to let them do it.
Start brewing it. My son's making birch beer.
That sounds fantastic.
Just all you have to do is distill it and you have whiskey.
There you go.
I can show you how to do that. It's pretty simple chemistry. So.
Yeah. Well, that's why we have a tap on a birch tree outside, and my son's making birch beer.
Fun.
So, Matt, I have a funny question for you, Matt. Then I wanted to bring up another subject, too, if I can. One thing that puzzles me, if you look at the state data, it reports how many people were tested, which is right now somewhere in the neighborhood of 56,000 people or so. And it says that they're in the neighborhood of 7,000 positives. So roughly, I would have thought that we're only giving tests that people are fairly highly likely to be positive. In other words, I've heard of people getting tested for the regular flu first, and if they are negative to the regular flu, they might get the COVID test. We're only getting, if you look at those numbers, we're only getting, of all the people that have been tested so far, 15% positives. That seems like a low number.
So what I think the take home for me from that data, I think one goes back to the point that kind of came up earlier, that some subset of those are likely false negatives, and that those
False
may be
negatives,
high-risk patients.
Yep.
So that's a chunk of it. And I think the other piece is that the COVID syndrome is really heterogeneous. I think there are a couple of pieces like Lisa was describing for her daughter with a kind of the loss of the sense of taste and smell. It seems fairly specific, but I think that's only like 15% of cases. The things that they sort of often describe are, the kind of fevers, achiness, and for a subset of patients, a profound fatigue. The loss of the sense of smell definitely seems like one that's more specific. But, we sort of have had a medium bad flu year, and there are lots of people who have various syndromes that may result in testing. And so I think we're seeing a increasing proportion of tests, or what I would suspect is as we get higher disease prevalence in the community, I suspect we'll see an increasing prevalence of positive tests as percentage of total tests sent, even as the number of tests go up. So I think that so I would say I'm like a little bit surprised, a little bit reassured, and a little bit it's a snapshot in time.
Yeah, that's all true.
I think, Lisa, you should call the state DPH number. I can give it to you because that sounds like it absolutely meets the criteria for testing at the state. And they've made it point over and over again at our daily staff meetings that it doesn't go through the PCP. It goes through the state number. You have to call them directly.
No, but you have to get, if you're not an at-risk person with not severe symptoms, they tell you to call your doctor first. So
well, that's not what I'm being told. There's a separate number for the non-MDs, non-in-house, high risk and high priority people.
But she's not.
But
She's
I
not
would-
high risk, and she's not high priority.
Right, but I would also say, like,
with your daughter, I can give it to you. You can call it.
It's too late. She's done. She's all better.
Okay.
yeah, no, I would say if she lost her sense of smell, I would not bother with getting more testing in that setting. I would say she most likely has COVID, and you better pick which kid's your favorite.
Yeah, no, this is 3 weeks ago at this point. She's good. Like, she's gotten everything back. And
Also, if it wouldn't change your behavior, right? If
Right.
you
I mean,
self-isolate and all the rest,
Right.
what's the point of a test?
Exactly.
Than for data.
Right.
But since
There's not
we're
enough
recording,
tests for that luxury of
Right.
better
Oh, we
data.
probably shouldn't be talking about her.
What would be valuable would be.
but can we pin down which kid's your favorite?
Bodies. She could go into the research for antibodies for the potential information that's missing, which is whether or not if you've had it, and it sounds like she has by clinical criteria, does she have
Right.
antibodies that's valuable for the
Yeah.
information? you're looking
Matt,
So-
definitely let me know when you hear that they want to start doing that in the general population, the serum testing, because I
Yeah.
would definitely be interested in that.
Will do.
Okay.
I bet Ellen $20 that even though we were digital, we could still finish by 9. Do folks feel like we're
9
on track?
o'clock, so now's our chance.
Well, I just want to mention one other thing. We don't have to discuss it. We have a select board meeting tomorrow night, and one of the things on the agenda is whether we should declare a local emergency for the town of Sherborn.
Yes.
And so we won't have to discuss it here tonight. I can send Ellen maybe the 2 slides I created. Zach is editing them right now. My punchline at the bottom is really that there doesn't seem to be any benefit to declaring a local emergency, but conversely, there doesn't seem to be any drawback to doing it. And Zach feels like it'll send a positive message to the residents that we're, really need to reinforce this physical distancing and that the town is actively managing it. So I'm
If
not
it
sure.
affects human behavior, I think there's a benefit.
Yes, we don't know that for sure. One thing it does allow you to do, it allows you to have non-medical personnel perform sort of minor medical tasks under the supervision of a medical clinician. So if we were short on staff and all of a sudden had to, didn't have enough EMTs or something, we could maybe send someone out, with an EMT crew that's supervised by the EMT. I don't know, but anyway, I have 2 slides that talk about the pros and cons, and we'll see what the select board thinks tomorrow night. So we don't need to discuss it here. I can send the slides to Ellen, and then in case you're having insomnia a second night in a row, you can dial into the select board tomorrow night.
What a nice invitation. All right, so do we want to end on that high note of an opportunity for another meeting tomorrow?
Yes.
Yeah, even though it cost me $20.
Really?
Sure.
No.
Oh, okay.
It's 9:02.
All right, guys, have a great night and make sure to watch Tiger King.
Thanks.
Okay.
Thanks.
Done.
Bye, guys.
All right.
Bye.
Nice to hear your voice again, Matt.
Ciao, guys.
Bye.
Bye.